A patient arrives in the emergency department in acute liver failure. The clinical suspicion points immediately to viral hepatitis, but when the initial lab results return, both the hepatitis B surface antigen and surface antibody screens are completely negative. The common and often catastrophic cognitive error here is assuming that negative surface markers equal a negative infection. In reality, the virus is actively proliferating inside the hepatocytes, entirely invisible to the standard screening panel circulating in the serum. We need to map the precise temporal kinetics, chronological windows, and extrahepatic cascades of hepatitis B and C. By doing so, we eliminate these diagnostic blind spots. To do this, we will reconstruct the serological timeline from the ground up and immediately test it against multi-layered clinical scenarios. Accurate staging of viral hepatitis relies entirely on anticipating these invisible temporal gaps and recognizing distant systemic signs when the liver itself provides no clear answers. This chart establishes our temporal framework. It plots the progression of acute hepatitis B serologic kinetics, tracking serum titer concentrations over the weeks following initial exposure. The sequence begins with the surface antigen search. HBsAg is the first detectable marker of active replication. It is immediately trailed by the E antigen, or HBeAg, which indicates a state of high viral infectivity and active transmission risk. Then we enter the immune clearance phase. The host's defenses mount a massive counterattack, successfully driving the surface antigens down to undetectable levels in the serum, long before the host can produce protective antibodies. This creates a distinct, highly vulnerable phase where standard surface testing fails. During this time frame, the hepatitis B core antibody, specifically anti-HBc IgM, is the sole positive serologic marker available to the clinician. A standard acute infection presents with positive surface and E antigens, but inside this isolated window period, the profile shifts entirely. The surface antigen is negative, and the protective surface antibody has not yet formed. Consider this clinical assessment. A 52-year-old man with recent intravenous drug use presents with severe jaundice. His AST and ALT are markedly elevated to 250 and 300, yet his hepatitis B surface antigen and surface antibody both return negative. Testing for hepatitis C or ordering autoimmune markers like anti-smooth muscle antibodies might seem reasonable given the transaminitis, but doing so misses the immediate temporal threat. Those options ignore the specific timeline of the viral clearance phase. The correct diagnostic step is testing for the core antibody, anti-HBc IgM. Because the patient is squarely in the window phase, this assay is strictly required to confirm the acute infection. Failing to specifically order the core antibody during this precise chronological gap guarantees a false negative clinical assessment and delays critical supportive care. Moving beyond the acute phase, we must differentiate true natural immunity from iatrogenic immunization. This matrix compares the serologic markers across 3 distinct post-acute outcomes. A cleared natural infection leaves a specific resolution signature. The patient will present with protective surface antibodies paired with the long-term presence of anti-HBc IgG. Recombinant vaccines yield a different profile for an exact virologic reason. They are synthesized using only the viral surface proteins. Consequently, the patient develops the protective surface antibody, but they produce absolutely no core antibody signature. Finally, chronic immune failure occurs when the virus evades final clearance. The diagnostic threshold here is the persistence of the surface antigen beyond 6 months, accompanied by core IgG, without the critical formation of protective surface antibodies. Let's test this model. A healthcare worker suffers a deep needle stick injury from an unknown source. Stat labs are drawn. The results show a positive surface antibody, but completely negative core IgG and surface antigens. Administering hepatitis B immune globulin or starting antiviral therapy like tenofovir would be a clinical error. The patient is not acutely infected, and they already possess the necessary protective antibodies to neutralize the exposure. Standard wound care is the only appropriate step. The isolated presence of the surface antibody, paired with a negative core, definitively proves prior successful vaccination. The presence or absence of anti-HBc IgG acts as the absolute arbiter of a patient's historical exposure to the wild-type virus. Hepatitis C presents a distinct virological challenge. Unlike hepatitis B, where the presence of the surface antibody grants immunity, a positive anti-HCV IgG only proves prior exposure. It provides zero protective immunity against active or future infection. Because the antibody cannot clear the virus, diagnosing an active, ongoing hepatitis C infection strictly requires quantitative confirmation. If the antibody screen is positive, the mandatory next step is an HCV RNA PCR to detect the viral load. Chronic hepatitis C is not confined to the hepatic parenchyma. The virus triggers a systemic immune response, generating massive amounts of dense, tangled immune complexes that precipitate out of the blood and become lodged in delicate capillary beds. This drives specific extrahepatic pathologies. The first classic link is essential mixed cryoglobulinemia. These patients present with palpable purpura, severe arthralgias, and distinctly low C4 complement levels, as the immune complexes consume the circulating proteins. The second classic link is porphyria cutanea tarda. This manifests as fragile, blistering skin, strictly localized to sun-exposed areas, most frequently the dorsum of the hands. We can identify this in practice. A 50-year-old male presents with chronic fatigue and mild transaminitis. Following a weekend of playing golf, he develops new-onset severe blistering on the back of his hands. Initiating a purely rheumatologic workup for anti-nuclear antibodies or consulting dermatology for isolated skin biopsies ignores the mild hepatic footprint underlying the entire presentation. The blistering is porphyria cutanea tarda, driven by an underlying infection. Ordering the HCV RNA PCR is the definitive next step to confirm the true etiology of the dermatological symptoms. By recognizing these distinct extrahepatic signs, the clinician can diagnose and treat the underlying hepatitis C infection long before it progresses to overt cirrhosis. We have isolated the two primary clinical challenges of viral hepatitis: the temporal invisibility of hepatitis B window period, mapped here on the left, against the systemic camouflage of hepatitis C, shown targeting the skin and kidneys on the right. The absolute rule for hepatitis B is to always isolate the anti-HBC IgM. It is the only metric that can close the diagnostic gap during the acute window phase. To verify immunity, read the immunological scar. The presence or absence of anti-HBC IgG instantly differentiates the successfully vaccinated patient from the previously infected host. And when evaluating extrahepatic presentations, look past the integumentary system. Unexplained blistering skin lesions or palpable purpura are direct indicators to screen for hepatitis C. True clinical mastery of viral hepatitis requires understanding these underlying kinetics. It means knowing exactly which serologic marker to trust when the most obvious ones disappear.